It's great to come to Poland. This is my first time. So I'm going to be talking to you about digital technologies. And I want to ask you a question first, and you can put up your hand. Digital technologies are typically something, I think, they're a bit like Marmite that we have in England. You know, you either love it or you hate it. And there's colleagues like my friend Adrian, he loves anything digital. My wife hates anything digital. And I think I'm somewhere in between. So put up your hand if you're someone who really adopts and embraces digital. Okay, there's a few of you. There's a few of you. Put up your hand if you really hate digital. Oh, okay, no one's brave enough to say that they hate digital. And then put up your hand if you're in the middle. Maybe most of the rest of you are somewhere in the middle. Okay, so let's talk about where is the situation at the moment with digital technologies. I'm going to talk a little bit about the problem. Let's highlight the problem, and then let's talk about how is digital trying to answer some of the big problems we're facing at the moment. And what I'm going to do is I'm going to take you through 5 big policy documents that have come out in the UK. So these are policies that are trying to address the problems that we have. And I'm going to look at it through the English lens, okay? But I think probably you'll recognize most of this is not just for England, it's pretty global what's happening. And so we're going to go around, and the first one is around health inequalities. The public health piece is hugely important. Why is it important? Because back pain, as well as other musculoskeletal problems, clusters. It clusters in certain communities, okay? And it's because it's got drivers to do with age, to do with comorbidity, to do with ethnicity, to do with gender, but very importantly, to do with deprivation. Okay, we have a map here of our local region where I live. Here's my university, this is the city, and what you can see is the prevalence of chronic pain and just how it's clustered in certain areas, okay? And that means that our health service in this area needs to look very different than if you're in the dark red area. Your imaging might be 2 or 3 times as great. Your use of self-management might be much less, because you might need to do a lot more hand-holding of certain patients. So the first issue is around how do we deal with health inequalities? The second big issue is around streamlining access to care. Patients are having longer and longer waiting times. They're getting very frustrated, particularly in our national health system in the UK, because of waiting times for surgery, waiting times for even physiotherapy, up to a year, where I live now, if you want to have some physiotherapy. So we really need to see some streamlined information, because people can't just sit on a waiting list and not be given something. The next big thing is around improving diagnosis and referral. Unfortunately, in musculoskeletal and particularly back pain, diagnosis isn't straightforward. And we don't really find that there's a nice blood test. And we certainly don't want to be scanning all our patients. And that means that we need some specialist knowledge early to get the right diagnosis and to make the right referral. And at the moment, we've got a real problem. We're trying something in the UK where we're introducing physiotherapists to work in general practice as first-line clinicians. It's proving very difficult because you have to take the best, most experienced clinicians, and then you put them in a situation with very short consultation times and a lot to do. And it's quite complex, and we're getting a lot of stress, a lot of burnout in the people that are doing the FCP role. And clearly, you know, everyone's wanting to reduce the waiting times to secondary care. The next big issue is around the fact that we don't have integrated care. And there are sort of 3 elements that I would like to highlight around this. The first is about the increasing complexity that we have with our patients. They're getting older, there's a lot more multimorbidity, polypharmacy, and we need risk tools that are going to help us understand complexity. The second big area is around the push for personalized care. Patients don't want to just be seen, they want to be heard and they want their needs to be met. And they're increasingly vocal about when they attend, they're not getting a good appointment. And so we're seeing increasingly that patients are needing shared decision-making tools. Should I have an operation? Should I not? That needs to be discussed through. It's a two-way conversation. We're also seeing that patients need discharge plans, and they want that on their phone. They don't just want a piece of paper that gives them a discharge plan. So there's a big issue around there. And then the last big area is about the sort of seamless flow of information. At the moment, we have different systems, IT systems in different settings. They don't speak to each other, and it's just very frustrating, that lack of interoperability, the bottlenecks that we're seeing, not just in data, but in the way that we handle patients. And just the whole piece around handover is not working very well. Often patients go and see someone who they shouldn't have gone and seen that person. They should go and see someone else, and they get passed around the system. And this whole issue around efficient communication is a real issue. And the last one I'm going to talk about, if I can get the slide to move on, here we go, is about the fact that we work now in an environment where economically all of our countries are struggling. The funding is reducing. And my physiotherapy colleagues say, why aren't they giving us more staff? Why are we not getting more staff? We need more staff. And they're seeing that the waiting list is going up and up and up, and they're not being given more staff. And it's very, very frustrating, because the truth is we've got a reduced economy, and the capacity is just not there. So what are we going to do? How do we struggle with the workforce pressures when we don't have increases in staff coming, and they're not going to come? Yeah, let's get that clear. It's not going to happen. So we have to find some other solutions. And what you see in the policy documents is they see digital as the answer to the workforce pressures, the workforce stress. But I wonder whether you think that's working. So that's something we can talk about as a group. So there's my summary of the current 5 problems, looking at these key 5 documents, policy documents, that are relevant to musculoskeletal and back pain. Okay. And I have to say, in the UK, there's a real desire to push away from secondary care, from surgery, big hospitals, and try and push more into primary care, community care services, because historically there's been a real imbalance, and that continues to be a real problem, managing that difficult transition. Okay, so let's now talk a little bit about how technology is starting to sort of interact with each of those problems. And I don't think it has all the answers, but we can have some discussion together about it. So firstly, I want to talk about some examples to do with big data, trying to tackle the issue of the inequalities that we're seeing. What do we do with the fact that we've got so many more patients who are really struggling to work, who are much more disabled in some areas than in others? So what we've been doing is a big project called MIDAS. It's a 5-year program all about how to sort of link data together from different settings right across the pathway. The public health piece, population level data, GP data, physiotherapy data, secondary care data, link it all together, look at bottlenecks and try and work out what's happening. So just to show you a little bit about the design, we've taken this large area of the population, around 500,000, and then what we've done is we've looked at, across the 70 GP practices, we managed to get 30 of them to agree to doing part of our research project. And we're doing 3 big projects. One is around the population. What's the severity? What's the difference across the different areas in terms of the need around back pain and other musculoskeletal problems? How is that need being met through a GP practice survey? And then what's happening as well at the physiotherapy end, and linking all of that data together so that we've got the public health and the healthcare piece working together. So that's the design of the project. The data sources, there are 3 data sources. One of them is around what I call organizational and social drivers. Okay, so we're using a whole range of, at the heart of it is the individual. And in some things we sort of look at a place-based information, a little bit more sort of council-based, it's sort of government-run data. And then there's more healthcare data. And we're trying to sort of put those 2 things together. Imagine that I find that the opioid prescribing is different across the 30 practices. What I need to know is, well, what's driving the difference, the variation? Is it the social determinants? Is it to do with the ethnicity, to do with the deprivation, those sorts of things? Or is it to do with the organisation? Is it that they have longer waiting times, they have shorter appointments, they have more locums, there's more problems with translation in the consultation? What are the drivers? And that's what we're starting to look at with this project. So those are the organisational factors. And then we need the patient outcomes, and we look at both patient experience and patient outcomes. And we have a standard battery of measures that you can see on the right-hand side. And then the last thing is we look at the primary care record. We look at what's happening in the electronic health record, and that gives you a whole list of different things around management. What's actually being done, like the opioid, or the investigation, or the referral, or sick certification, all those sorts of things. So we're getting all of that data from all these GP practices, and we've just had it back. It's all being put together at the moment and cleaned and prepared. And our purpose now is to put that into dashboards and into performance reports that the GP practices find as really helpful, that the commissioners find useful. So the commissioners want slightly different information. They want to know about where is the need, what is the provision, and where is the gap. Okay? That's what they want to know. The GPs want to know, well, how well are we doing for our patients? And are we above the others, or are we behind? And in which areas are we behind? And across the UK at the moment, when you think of back pain, musculoskeletal problems, we only have national audits in secondary care hospitals. We have nothing in primary care for this space, and yet the majority of patients are managed. By far, the majority of patients are managed in primary care. So, and we have a data invisibility problem in primary care. So we know that tech can be quite powerful. People hate tables, but they like an infographic. Yeah, if you can get a strong infographic, a picture speaks very powerfully, a bit like the map I showed you. So we're looking at all the different indicators. I have a poor PhD student who's recently identified all the quality indicators in the literature, and he came up with 400 indicators, mapped to 12 different themes. And now we're going through a process nationally of trying to get some consensus. What are we going to use as our sort of improvement-driven aims? We're going to need somewhere between 6 and 8. They need to be decided nationally, and we need to start reporting those. And we're actually taking this project from a local area. We've now got funding to do a national MSK audit and pilot in primary community care. But I can tell you already that we're seeing that things have deteriorated significantly post-COVID. The amount of severity at intake is worse, so our patients are more severe, and the amount of change that we're seeing over a course of treatment has gone. We're using something called the musculoskeletal health questionnaire, and it used to be on average about a 10-point change. Now on average we see about a 5-point change. So we're getting about half the treatment that we used to get. During COVID it was under even a 2-point change. People were almost better off not getting any treatment at all. So clearly there is something around the importance of using digital for health informatics so that we can look at variation, we can identify best practice, and we can emulate it. So I've just highlighted that there as the first thing. But there are some real downsides to all of this. You know, you can say, Jonathan, you make it sound so exciting, so good, but the reality is quite different. You know, the reality is that clinicians are tired of entering data. Not more data, not more forms, please go away. You know, I want to look at the patient in the eye. And the data often that we get is of poor quality, and it's not of good quality, because it takes away often from real care, and that's what really matters to people. So we have to be clever if we're going to do this and do it well. At the moment, we still haven't quite nailed our improvement-driven metrics. I wonder in Poland, do you know what your improvement-driven metrics are? What are you trying to improve nationally at the moment in the world of back pain? Have you nailed 5 or 6 like they have in stroke patients or cardiovascular, and that's what you're trying to target? Because that's what I see that we don't have for primary and community care. We have it for secondary care, but we don't have it for the big area of primary care. The truth is sometimes decisions are political. We saw that in COVID. You know, they had the data, they knew what they ought to be doing, but then the politicians, like Boris Johnson, decided something completely different. Yeah? And we also know that the public are rather worried. Can they really trust their data going off? Because big business is going to buy the data and is then going to use the data. So we have a real problem around that. And everyone is asking this big question, particularly the clinicians. Will AI make it better? Hands up if you've had an email asking you to use one of these listening medical electronic record-taking things. Is anyone getting that here yet in Poland? I've had emails, I don't know how many this week, saying, Jonathan, you know, you need to be trying to think about this new product called Nuance. People might know. It listens to the consultation, records the consultation, puts it through like ChatGPT, and all your medical records come out structured for you the way that you currently do it, using fine-tuning. So that is the direction people are seeing. They're already being tested in lots of different clinics. People using natural language processing to help with the medical record-taking piece. Because if we can get it from free text into structured data that is then coded, we can then do all the work that I was talking about earlier that we're doing on the electronic health records. What about poor access to care? Well, at the moment, I've highlighted some areas. Adrian and I have recently sat for a nice panel that's been called an early value assessment of digital technologies for back pain in the UK. And the reason that that's been needed is because services across our country are commissioning digital technologies without any evidence, without any national guidance about which things have evidence, which ones don't. And they wanted to know, essentially, which ones have independent research evidence, which ones don't have independent research evidence, it's produced by the company, and which ones are unsafe. And we've had 15, and we've had to allocate all 15 products. Some of them are being used already across many, many trusts and different hospitals in the UK. And that's coming out in January. I'm not allowed to tell you the results. But I can tell you that you ought to look at some of these different products. Selfback has a trial behind it. It was an EU-funded app. It's a Danish-owned company now, but the Norwegians were very much involved in doing that with the British. Get You Better is one of these apps where, you know, again, it just supports self-management. Supportback was an academic-led project from Southampton. I was very involved in Supportback, and the Lancet paper is hopefully going to come out fairly soon. Then we have things like Flock Health, Joint Academy. They're all, in my mind, they're a bit more than just information giving. They're starting to try and tailor the information to the profile of the patient. They're trying to monitor the patient. Selfback even has AI looking at the patient's profile, looking at their step count, looking at their pain levels, and choosing the exercise program on the back of all of that information. Okay, so they are moving forward in that direction. If you're not aware of them, do use them. They're slightly different to exercise prescription only, where I, as the therapist, might choose these exercises, and rather than you get them in a piece of paper, you get them online. There's things like PhysiTrack and Rehab Guru. We have lots of those all around the world now, which are a bit more exercise focused. These ones are a little bit different. So what are we seeing? We're seeing information giving via tech. We're seeing self-management apps, which are a step up from that. We're seeing exercise prescribing. There are a number now of psychosocial support that you can get online or virtually. We're seeing things like virtual therapy starting, where you can sign up anywhere in the world to have a physiotherapist who meets you virtually, tells you what exercises you need to do, monitors you, and the whole thing's done virtually. A very big company in the US called Hinge, with a lot of backing behind it, is currently trying to break into the UK market. It might be trying to come here to Poland, I don't know. But this is growing. This whole virtual therapy piece is really growing, and it's quite international. We're also seeing lots of clinical decision support tools and systems. I'm involved in a couple of trials which are testing those. Some of them are AI-based, some of them are algorithm-based. But essentially the pathway gets written down, the pathway then gets transferred to software that presents that to clinicians so that their decisions get easier and easier. It can either take you down a diagnosis route, it can take you down a prognosis route, and it can suggest for the patient in front of you what's the best treatment for this individual. We have things like triage support. So what do I mean by triage support? So triage support is working where maybe a patient wants to see a GP like Adrian, they have to complete a form online, and then there's an algorithm working behind that says, actually, you don't need to see the GP, go and see the nurse, or maybe you can go and see the physio, yeah? And we have the same just in physiotherapy now. We have something that is doing all the triage piece, because in the UK we have a lot of self-referral, patients coming to physiotherapy directly. There's lots happening around communication between patients and clinicians, particularly around dashboards. So you can see how well is your patient doing their exercises, is their pain going up, is it going down, what about work, etc. And lastly, we are going to see a huge amount coming in medical record taking because of the natural language processing, listening, recording the consultation, it being turned into text, and then the clinician just saving the structured sort of form that gets filled out automatically. Now, what NICE has recommended is that the evidence is so poor for most of the products. A few products have a trial behind it, but most of the 15 products we've looked at don't. So they need to start collecting evidence on these sorts of things. And I have to say that we know that we have a big problem with the self-management apps. While they look really good, if you ask for the adherence, how many patients are still using it at 30 days? You'll see it's, if you're lucky, 10%. Yeah? At 6 months, you're lucky if you get 1 or 2 patients still using it at 6 months. And even things like the support back that I was part of, we looked at how many times patients were accessing the information. They only go in a few times. On average, they only look a few times, and they don't spend much. It's somewhere between 3 and 5 minutes. So they don't spend a long time on these things. So let's be realistic about where this is all going, and that's the kind of information we need. So the current reality around all these self-management apps is that while we're being encouraged to push them, support them, we know that engagement is low, behavior change and social components are largely missing. There's something called an abacus scale, and it measures how many behavior change techniques are within each app. And a recent systematic review showed that most of the current apps, this was a Danish project, have very few of the different behavior change techniques embedded, and even less have social components. How many people here use Duolingo? Anyone here like Duolingo? Well, there's a few of you. But there are some other programs like Strava. Anyone know Strava app? Yeah. What they do well is the social piece. And yet we don't have our health apps tapping in to those things yet at all. And that they're really struggling, therefore, with engagement. And so that's where we see things having to go. A couple more things. Adrian is going to talk in his all about cross-cover and ortho pathways. So I'm not going to talk about that. Pheo Access is the one I said about self-referral. Patients complete it online, and then it decides everything from should they go to the emergency department, to the GP, to the rheumatologist, should they go to the physio, what level of physio, should they go to the pain clinic. All of that is happening through these, and these at the moment are algorithm-based, but it won't be long before they've got the data sets available to do an AI version. In fact, I recently went for funding with Pheo Access. They had 500,000 patients, they had the clinical decision, they had everything on the form, and they just want AI to make everything much shorter and more efficient and more accurate. Okay, so this is coming. This here, Optima Health, DART, it's a whole physiotherapy assessment, online, automated, with no therapist involved. Okay? It will do the whole piece, and it's being used in occupational health services now to just remove the physiotherapist. Okay, so that's something that we're seeing come. At the moment, the evidence is still small. They're early products. They're not very advanced yet, but you can imagine where this is going over time. this is something that Adrian will talk about, but essentially this particular one, orthopathways, once you get to your diagnosis, it tells the clinician, this patient has this diagnosis, this is how you signpost, this is where you should send them for self-management information, this is the management you should consider, and this is when the patient needs to come back for follow-up. All right, and it's all then delivered to the patient's phone in a patient-facing kind of version that the clinician can just say, yep, I like that, and it gets automatically saved in the record. Right, couple of things before I finish. I'm using up my time, but what about the integrated care and complexity? We've already heard a little bit about StartBack and other risk tools. They started as sort of paper-based, then they went to electronic. Now they've gone to things like individual risk prediction. So predicting for an individual patient, what's their pain level going to be like in a couple of weeks? How likely is the individual to have time off work? Yeah, predicting those at an individual level for this patient in front of us. And then in the future, where that's all going is automated risk prediction, looking at the patient's record and then doing trawling in the background and then telling you what the prediction is for this individual. Other big areas are things like shared decision-making tools and patient-held discharge plans. And I don't know if it's something that you're being encouraged, but in the UK, there's a really big push around trying to get us to use decision tools with our patients. And I just thought I'd show you what does that look like. So if I stop the show just for a second. Okay. I can do it. It's full. He said, oh, no, it's not working. Well, it doesn't. Ah, there we go. So this is what a decision support tool looks like. So you go to a website like this, and there are decision support tools for back pain, shoulder pain, hip pain, and it's all about, I don't know, should the patient have hip surgery, for example? So if we look at that one, thinking about surgery as an example, what it encourages you to do, once the patient's written the name, they say what they want to come for help with ahead of the appointment, and then there's a whole load of different things they can do for themselves. But it talks through about should they have surgery or not, what are the possible risks, and the idea being that this gets given ahead, is talked about in the consultation, and then what we did is we did a project where we digitized all of this, and then depending on what was decided, the patient got the information through on their phone as a completion. So I'll go back to that one. Thank you so much for doing that. And that was an EU-funded project called Backup. So you can see where all of this is going. You can see the sort of direction of travel. I just want to ask the question as I finish. Do you think digital is working for you at the moment? If everyone is saying it's there to reduce your stress levels, it's there to help reduce the work pressure, I don't think anyone is going to say, yes, that's really working for me yet. But I think we can see the promise. We can certainly see that with AI, that might make a difference once they get the medical record piece working for us, because we all hate writing down or dictating our letters and all of that work. So in summary, there's a whole load of patient-facing tech. There's a whole load of clinician-facing tech. And then there's the whole informatics piece, all right? This is where we're going. That's what's happening. I think what we need is more evidence. Everyone says that, don't they? But we definitely need more evidence before we go too far. The recording of your consultations is coming, I predict, in the next couple of years. I think hybrid working, if you're a physiotherapist, is coming very soon. It's not going to be face-to-face or digital. It'll be a hybrid mix. You'll maybe do your initial visits, you'll have a few follow-ups face-to-face, but all the in-between bits are going to be done online. And the reason that that's being pushed in the UK is all about the net zero agenda, and it's all to do with sustainability and climate change. And increasingly, that's where the targets are going to be. Performance dashboards are coming. If you don't have a performance dashboard already, it will be coming soon, because with tech comes all the data, and then comes all the possibilities to actually measure how well we're doing. But we do need to see the behavior change built in. And it's not just behavior change for patients, it's behavior change for clinicians. Because this is a whole transition that we have to go through. What's happening among our own area is that we're seeing certain clinicians are putting their hand up and saying, I'd like to be an early adopter of digital. Let's form a network, and when anything new comes, can we be the first ones to test it? And if we like it, then we'll tell our friends and it'll grow. And that's proving really popular. So we've got a real opportunity for us to do research with those early adopters. And I think if you're keen on it, you should form yourselves into a network and start testing things out and see what works for you. Don't just let people start commissioning and using without good evidence. Make sure that you don't reduce your care and attention to your patient because of tech. I think we all know that, but don't turn away from the patient and turn to the computer. We mustn't let that happen. And let's be realistic. I think I've hopefully shown you where the vision is, but also given you a sense that we've got a long way to go before this is really the answer. I hope that's been interesting. Thank you so much for listening.